Pandemics, Past and Present. A conversation between Dr. Rosanna Salvaterra, Medical Officer of Health for Peterborough Public Health, and Dale Standen, President of the Peterborough Historical Society, June 16th, 2020. Good evening, everyone. The Peterborough Historical Society is privileged to have with us Dr. Rosanna Salvaterra, Medical Officer of Health for Peterborough Public Health. No subject has been more in the news and on people's minds than the current COVID-19 pandemic. Of course, pandemics are nothing new in history, but it has been a century since a disease as contagious and life-threatening has swept the world. Dr. Salvaterra has kindly agreed to engage in a conversation about pandemics, past and present, and to explore some similarities and differences. From the knowledge and experience she brings to the subject, we anticipate learning much, not only about the nature of pandemics, but also about the role of public health measures in managing pandemic diseases. Okay, well, there are a number of questions. Pandemics are not something common in our generations or the past couple of generations lifetimes, at least not like this one. And for me, it's particularly almost out of body experience to be living through a pandemic after having 2 years ago researched and written a short essay on the Spanish flu in Peterborough. Mm-hmm. I couldn't believe that I was reliving that history in so many ways. Right. And so the idea of thinking about comparisons is not certainly unique to me. Many commentators have done so, and the Spanish flu is certainly the previous pandemic that everybody is referring to. But there are a number of things that I would like to hear Dr. Salvaterra's reflections upon in the comparative way. And certainly one of them is on the origins of the Spanish flu and the origins of COVID-19. Mm-hmm. We really don't know where the Spanish flu originated, where it came from. There's evidence of sporadic severe respiratory illness in Kansas in the spring of 1918, in some United States Army barracks elsewhere. And of course, there was the severe outbreak in Barcelona in Spain, which gave the name of the Spanish flu, because that was the first one that was really widely advertised or broadcast. But there was also a severe influenza epidemic in China in November and December of 1917, mm-hmm. and throughout the winter and spring of 1918. Wartime Chinese laborers who were brought into Europe to replace the European men in the trenches brought that influenza to Europe and possibly to Canada en route, because many of them came to Vancouver and then across Canada and out Halifax overseas. So the origin of the Spanish flu is ultimately uncertain, and historians have not, they have their pet theories, but we really don't know where it originated. The origin of COVID-19, on the other hand, seems to have been pinpointed to Wuhan City in Hubei province in China. And my question is, can we really be confident of where COVID-19 originated?
Well, I think the origins of COVID-19 are still yet to be confirmed. But I'm pretty confident that eventually we will know where it came from. I think we understand that many of these novel viruses that infect humans have origins within animals. So they're zoonotic. These are zoonotic diseases that cross over and infect humans, which makes them novel. And we know that with both with SARS, and which is another coronavirus, and with MERS-CoV, which is another coronavirus, we know that the origins seem to be from bats. And when they do the molecular fingerprint, the COVID-19 coronavirus is very similar to both MERS-CoV and SARS. So the idea, I think it's probably most likely that it did originate in bats, that there may have been an intermediary species. So for SARS, it was civet cats. For MERS-CoV, it's camels. And camels are the reservoir, and it continues to be an occupational threat to camel herders. For COVID-19, the thought was that it was an animal called, here, I wrote it down, because it's not an animal I know. It's pangolins, but I think eventually, whether it turns out to be that animal or another, I think we will know what the origin is because of the science that we have available to us now that just wasn't available in 1918.
That's really quite fascinating that it may have been transferred, say, from bats through another species to humans, because my understanding is that influenza tends to be naturally in waterfowl, and that it normally is transmitted, novel viruses of influenza are transmitted through pigs, swine, quite often, that's the case.
So that's one of the similarities between coronavirus and influenza, is that animals seem to be the natural reservoirs, and that there's this opportunity for the virus to mutate and then jump through to another species, particularly humans, and then infect us in a way where we have no immunity. And that's the perfect recipe for a pandemic.
I've read, we were speaking of novel viruses here, I've read that pandemics are always caused by novel viruses. Is this true? And can you help us understand the differences between novel viruses and, say, endemic ones that are around all the time?
Yes, so the reason why it's a pandemic is because there is no immunity within humans. We are all susceptible. And so the illness can, if it's particularly virulent, can really be quite significant. And the reason we have no immunity, we haven't met this virus before, and our immune system doesn't recognize it, is because it's coming typically from an animal reservoir, an animal source. So if you look at many of the emerging viruses, or most, they tend to be viruses that have become quite threatening to humans. They've come from animals, typically from often when humans start to inhabit areas that that's new. If they start to cut down rainforest and move into areas where these viruses are quite prevalent among the animal reservoir, then we become exposed. So pandemics are always caused by a novel virus. Once we've met the virus and we acquire immunity, typically it becomes endemic. And so, for example, there are already 4 coronaviruses that are endemic to humans, and they cause cold-like symptoms. So they're very mild illnesses, but they circulate freely among humans. Most of us encounter them, we get them, and we create antibodies to them. And typically when you've got enough humans with enough immunity, you can keep those viruses at bay. And so that's, I think, where COVID-19 will eventually land up in maybe 2 to 3 years from now. It may just become endemic, but right now it's novel, and we're dealing with that.
Okay. The alarm, of course, over COVID-19 is you don't just get a cold from it, you can die from it. I mean, there's a fair death rate. The death rates of the Spanish flu and COVID-19 seem similarly high, though the age demographic of the most vulnerable seem to be quite different. Spanish flu led to unusually high mortality among healthy adults, aged 20 to 45.
Right.
There's a really curious curve there. COVID-19 has been most lethal among seniors and those with compromised health, as the reports go. The mortality rate for Spanish flu lacks certainty because of the ambiguous data. The data wasn't kept as well, and of course, it wasn't understood as well. Do we have an accurate idea yet of COVID-19 mortality rates?
No, we don't. We will. We will get an accurate rate. It's still too early. The reason why I believe that we will get an accurate rate is because we have such a good diagnosis for it. We have a good diagnostic test, and that's because we actually have molecular testing, so we can identify the organism. And it's reportable. So COVID-19 was made a reportable disease, which means that labs that diagnose it must report it to the local medical officer of health. So we won't miss any cases where there's been a lab test done. So I am confident that we will eventually understand what the case fatality rate is, but we don't know now. And that's because we still don't know the denominator. Like we know, so for example, if you have 10 cases, 10 deaths from COVID-19 and only 10 people got it, well, you know it's got a 100% case fatality rate. But if there were 100 people who got it, or maybe there were 1,000 people who got it, or maybe there were 100,000 people who got it, you'll see how the denominator influences the case fatality rate, the mortality rate. And so until we have a good sense of that denominator, we won't be able to calculate that. And we won't know the denominator until we do other kinds of testing. And for that, we really need serology tests. We need to be able to do a test on you to see whether you have antibodies against COVID-19. And that would then indicate that in fact you were infected and you mounted an immune response. And the kinds of studies where we use serology tests are called seroprevalence studies. We're now about to start those. They're actually beginning. We have some validated tests. There's a test that's been licensed in Ontario, a serology test. And the seroprevalence tests are beginning. So we will at some point be able to calculate more accurately what the mortality rate, what the case fatality rate is for COVID-19. But right now, we just can't do it.
There is that current focus on the need for testing for COVID-19 and on the capacity for contact tracing. That's very much in the news now. In 1918, there was no means of testing for the Spanish flu. We had no idea. Only when someone presented symptoms would isolation and quarantine and contact tracing begin. And this was done inconsistently among jurisdictions as well. So that underscores how unreliable some of the data is. In Ontario, there was no requirement to report cases of influenza back in 1918 because it wasn't considered as dangerous as the other killer diseases like diphtheria or typhoid or others. They were all reportable. So we don't have really accurate data. There's historians' estimates vary greatly. They've ranged, depending upon jurisdictions, between an morbidity, an infection rate of between 20% to 50% of the population, but it really isn't known. And with present day testing accuracy and data collection, we don't have a reasonably accurate estimate right now of its morbidity, but will we, if we test enough, or is it likely that we're going to test enough and have that data at our fingertips?
Yes, I think we will. I mean, already even when COVID-19 was limited to China, we were getting case series reports being published in the literature, and because they were reporting these diseases, they were able to collect enough cases that they were able to get a sense of the morbidity from COVID-19. And that's where the estimates first came, where we estimated that about 80% of people will have mild disease and will not need hospital care. We know that of the 20% that do get infected, we understand that, once you hit 70, and 70 seems to be the threshold, once you're over 70, the morbidity increases significantly, which is why the recommendation right now is that everyone who's 70 or over should continue to self-isolate. We also we were also able to determine from the data from China that certain risk factors put people at a higher risk of dying from COVID. So people that had underlying or any kind of disease that really creates a bit of immunosuppression, so diabetes as well, they are all at higher risk of dying. All of this came from the data out of China, and it was replicated in jurisdiction after jurisdiction as COVID spread. So, so we do have, I think, a better sense of the morbidity. In fact, just yesterday, the CDC in Atlanta published data from the US where they were actually able to quantify the risk from underlying conditions, whether they were cardiac or respiratory. So I think we're understanding that a lot more. What we still don't know yet is whether Indigenous people are at greater risk. And remember, with influenza and with H1N1, we did see that Indigenous people were hit more significantly than non-Indigenous people. That data doesn't exist yet because there aren't Indigenous people in China. So it's really going to be a matter of continuing to observe the data, analyze the data. I think, besides COVID being a reportable disease here in Ontario, we also have our death certificates and vital statistics to draw from. So when a physician or a nurse practitioner is completing a death certificate, not only do they have to identify the cause of death, but they also have to identify the contributing factors. So by capturing that data on death certificates, again, we'll be able to understand better both the role of COVID in mortality, but also the role of these other underlying morbidities in severity for COVID-19. So the other thing we are understanding better is that there are socioeconomic risk factors, and that there's also racial risk factors. And again, the CDC data that was published yesterday showed that, for example, 33% of the COVID cases in the US were Hispanic, 22% were Black. And that, when you think that only 18% of the population are Hispanic and 13% are Black, you can see that in fact there seems to be a greater risk for people of other ethnicities. So I think the good news is that I would expect that in about 2 weeks from now, we will be collecting this kind of data in Ontario as well. Today, the government announced its intention to amend one of the regulations that will allow public health to ask for this kind of data. So people's racial heritage, their socioeconomic status. And if it passes, as it should in the next couple of weeks, we will also start to collect that data here. So we will get a better picture of the morbidity, but we'll also get a better picture of the risk factors.
Okay, that's the socioeconomic and ethnic factors are really quite interesting, because there were some lessons taken from the Spanish flu event afterward. People were noticed it, they took note. Perhaps most important, it focused more attention on the need to address public health. That was an issue, although that was also a rising concern much more generally. Locally in Peterborough, the medical officer of health right after the war, Dr. Angus McPherson, he laid out a 6-point agenda for improving public health, 2 of which points addressed the control of communicable disease and public health education. Those were 2 things that were he thought needed to be focused upon. And the attention to public health may also have helped the city to move ahead on a sewage treatment plant, which was built in 1922, and water treatment plant as well. So these ideas of improving public health followed the Spanish flu. Work of volunteers was very interesting also. And that was that they went into the homes of the sick people to take them food and to nourish them. And afterward, it drew attention to the connection between poverty and disease. Most of the homes they went into were of low socioeconomic, and there seemed to have been in the minds, this is all anecdotal, in the minds of those who volunteered to do this, that there was a connection there between the disease and influenza and socioeconomic position. Lessons from events of this nature are always very important. What lessons do you imagine we will take from COVID-19? If it's not too early.
Right. Well, no, there are some lessons, I think, already, because back in when we had our last pandemic, which was not very severe, it was a mild pandemic in 2009, 2010. I remember collaborating with others to write a chapter for the Ontario Pandemic Plan on the use of public health measures. And, we talked about, closing schools and closing churches, and but we never had to practice them with H1N1, and that's because we had a vaccine, and the vaccine was introduced, and we all turned our attention to getting people immunized. We just don't have a vaccine right now, and I don't know how long it'll be until we do. So we have to rely more heavily on our public health measures. And there's been research to show, there's been some modeling data to show that public health measures, when they are applied early in the pandemic, are very effective in actually delaying it and buying you more time to prepare. And that's exactly what's happened in Ontario with the closures of schools in March and the lockdown that happened and the imposition of these public health measures, we have bought more time to prepare for potentially if there is a second wave. The hospitals have had a chance to prepare. They've identified, where they can get more ventilator capacity. A lot of that work has been done. And we know that if you wait and you apply those measures later, what happens is you can flatten the curve. And these public health measures can actually together can prevent about 20% of the cases, but they can also prevent most of the hospitalizations and deaths. So I think we've had a chance to actually see the impact. We've done it, and we've been able to actually compare the experiences of places like Ontario or Canada with other places that did not lock down early as we did. And I think Peterborough was particularly lucky, because when the provincial measures came into place, we were about 2 weeks behind places like Toronto and Ottawa and Windsor. And so we benefited, I think, to a greater degree even than those other places where the outbreak had already started. So I think that's certainly a lesson learned. And I think if ever the need for a vaccine has, been obvious, it's been with COVID-19. And because, the difference when you have a vaccine and when you're able to protect people with a vaccine, I mean, I think, everyone's hoping that we will have one this year. I hope so, but there's no guarantee. And so we certainly, I think, are more than ever recognize the importance of having immunization and being able to protect people through vaccines.
Well, that's really really quite fascinating, because again, if we want to compare the Spanish flu, there were some historical studies. This is precisely the question that many historians were after, and medical historians as well. They wanted to know, did any of the public health measures practiced in 1918 have any effect whatsoever? And of course, they were all practiced a little late. But one study that took a look at a number of communities, a couple of dozen communities across the United States, came up with a statistically significant trend that those communities that imposed the public health measures earlier tended to have lower death rates. Mm-hmm. And there was one striking example: the city of Philadelphia, which deliberately didn't do anything, had the highest death rate from the Spanish flu of almost anywhere else in North America. It was catastrophic. And that was by doing nothing. So there were inklings even back then, when there were really no ways, or nobody had really done a systematic examination collecting the data that indicated that public health measures could help. And of course, locally here, of interest to us was that Peterborough did very well with the Spanish flu in 1918. It was much lower than the national average in its death rate, and we don't know, of course, about morbidity. And why that was the case, perhaps it was the medical officer of health taking a strong hand, even to the clergy who wanted to keep the churches open. He shut them down.
Yes.
But he did it rather late. And I think that part of the reason is because Peterborough was off the main drag, where a lot of the traffic, a lot of the transportation and movement of people was taking place along that corridor, Montreal, Toronto, and across the country. So in some respects, we hope that that history repeats itself.
Mhm.
So far, it seems to be, thanks to the measures taken by our health professionals and our Peterborough Public Health. That's a really interesting parallel. Well, I don't know, is there anything further that you would like to add, or any other reflections that you might want to offer us?
Maybe,
About...
I mean, I think you certainly identified a factor for Peterborough that it is important, and that's our geography.
Mhm.
and the flow of traffic and transportation, and the fact that we are, just that we're not located on the 401 corridor does afford us some protection. And certainly if we look at our neighboring public health area, which is Halliburton, Kawartha, Pine Ridge, they've been hit quite hard. And I think part of it is because the fact that they are directly aligned with that. They're on the 401 corridor and they're within commuting distance to the GTA. So Peterborough is just that, little bit removed and just a little bit north of the 401 corridor. So that does give us some protection. But I think if anything, what will remain with me long after, the pandemic is over is just how the resilience of the human spirit. And I think, with a name like mine, Salvaterra, my heritage is Italian and I have family in Italy. And Italy was devastated by COVID-19. But what will stay with me are those videos of the streets, the darkened streets of Siena and Assisi, where you can hear the people singing, and people coming out onto their balconies and singing, and it's just, trying to give comfort to one another. So I am so impressed by our resilience. I think it's certainly taking its toll, and I worry about our loved ones in long-term care, and I hope that we can reconnect with them and support them. It's been a terrible ordeal for them. And I think as well, it's been a good opportunity to experience what it's like to have to make decisions when you don't have all the answers. Because we are, the science is working very hard to catch up to us. Like, we still don't know about immunity. We still don't know, for example, masks. We have people wanting to make masks mandatory. The research, is evolving and it's emerging, and it takes time. So often we're making decisions and then having to go back and revisit them once there is more information. But it does, I think, challenge us to be very cautionary. And I think, again, it's been a really good experience, a good dose of having to make decisions when you don't have all the answers and having to take a precautionary approach. So there are definitely things that are going to stand out for me when I think back to this time.
Would you, perhaps there are some questions that our members would have. Would you take a few questions?
Sure.
Good. Okay, well, I'll unmute them then. I've got them all shut up here. So
They've been very quiet.
Yes. Okay, they can unmute themselves if they wish.
Oh.
That's good. So are there any questions? Susan. Oh, I can't hear you.
What's happened to her sound? Yeah, because you see, look at, I got the yellow. No, we can't hear her.
Is that okay now? Oh.
Yeah, yeah.
There we are. We have you now.
Okay, okay. When the virus first appeared, it took the World Health Organization a long time, it seemed to me, to declare it a pandemic. Is there a medical reason for that, or was that totally political?
No, I think it was justified because the first, at first when it began in Wuhan, and China was doing its best to try and contain it.
Yeah.
There was always the hope that it could be contained. And you'll
Okay.
remember that with SARS, even though SARS did spread to places like Canada, we were able to contain it. And that's because SARS was not as transmissible as COVID-19 has turned out to be.
Okay.
And so I think the World Health Organization was waiting and watching very carefully. They certainly called it a disease of public health concern. I mean, I can still remember in January that we were watching it very closely. And then as the outbreak did start to spread outside of China and to other parts of the world, it became clearer that this outbreak was not going to be contained, at which point they did declare it as a pandemic. And all pandemic means is that you have outbreaks happening throughout the world in different jurisdictions. And I think that's really more, there are two reasons why it did turn into a pandemic. One is that the organism itself is highly transmissible. It has what we call a high reproductive number, so that for every one person who has COVID, they typically infect 2 to 3 others, which means that it has a high, so it is able to spread. But I think it's also the impact of air travel. And the fact that nowadays, and we saw it with H1N1 as well, because of the connectivity of air travel throughout the world, it can take a virus just a number of hours to get from one country, across the world to another. And I think COVID demonstrated that when countries were identifying their first case, there had already been weeks of transmission usually by that time. And that's because of travel.
Okay. Thank you. Thanks.
Other questions? Just one comment of something that you said about H1N1. We do have a vaccine for that. Of course, it has to be changed every time H1N1 is estimated to be the influenza of the year, because they do mutate. But H1N1 was the novel virus that caused the Spanish flu.
Correct.
That's when it first appeared. And it's interesting to me that it's still a very nasty influenza, that it has not moderated a great deal by something that you seem to imply, that we're going to go after H1N1 because it's still a very dangerous influenza.
Well, influenza in itself, does cause, a significant number of deaths every year. So that's why Ontario has invested so heavily in a universal immunization program against influenza. And like COVID, for some people, influenza is a mild illness. For others, it's life-threatening. So we need to treat it with respect. And I certainly am a big proponent of annual immunization against influenza until we have a better vaccine. Because right now, as you said, the thing about influenza is that it's always it's always mutating, and it can't repair its nuclear material. So it tends to, these mutations then give rise different strains of the different strains of it, so that we are susceptible and we get infected. But it was actually, interestingly enough, the older people in 2009 who had been exposed to the H1N1, because it circulated widely following 1918. So 1918 H1N1 came in. It was brand new, novel. It killed between 20 and 40 million people. But then it continued, it became endemic, continued to circulate. And people born at that time acquired immunity, so that when the virus shifted and we had a new pandemic in 2009, it was still H1N1, and older people had immunity. So if you remember back to 2009, when the vaccine came out, we weren't immunizing elderly. Anyone over 65 did not get the virus. We focused on the younger adults and people with chronic disease, people who did not have immunity. And the people over 65 had some protection against H1N1. And we didn't immunize them until we got the younger adults done first. So it's interesting. It's just very interesting to see how these viruses emerge, how we become immune, how some of us then age, but continue to have that immunity with us. And if we meet that virus again later in our lives, we have some of that immunity that we can depend on.
Oh, well, that's encouraging.
Yes.
The good thing about getting older, and that's that our immune systems become much more mature.
Well, it's also encouraging that our own systems can give us that much protection. Over the years, we should trust our bodies a lot and be thankful for them. Dr. Salvaterra, thank you very much for this. I think we have kept you in the evening long enough. It was very good of you to agree in these changed circumstances. We could not provide you with a dinner, but at some point we will entertain you when we can all get together again.
I have my own coffee here too.
Yes, that's right. And we will engage in further conversations about, I hope, more pleasant subjects than pandemics.
Sure.
Hard to imagine more interesting ones. Thank you very much again on behalf of the Society.
You're very welcome. It's always a pleasure to be with you.